Good morning, good afternoon, good evening to those of you who have just joined us. My name is Mike Toso. I'm a program officer with Johns Hopkins Center for Communication Programs. This is our sixth in a series of malaria social and behavior change evidence-based discussions. Before we begin, I'd like to introduce our moderator, Don Dickerson. Don is based at USAID Washington and is a senior malaria technical advisor for the US President's Malaria Initiative and a member of PMI's Social and Behavior Change team. He has a master's degree in economics and over 30 years of public health experience covering reproductive health, HIV/AIDS, maternal and child health, and malaria. Welcome, Don.
Good day, everyone. Thank you, Mike. The US President's Malaria Initiative is supporting this activity, and I just wanted to say a word or two about how this fits into our global strategy to support high-quality social and behavior change. PMI prioritizes activities that improve countries' capacity to collect and use information. While this often means country-level data collection, it should, in a broader sense, also mean taking data and lessons learned in other countries and, when appropriate, using it to inform our own country needs. We are also very interested in building the capacity and health systems of countries we work with. From our perspective, regular discussions about rigorous malaria SBC evidence builds and maintains capacity among the malaria community. We hope this activity meets your needs. Over to you, Mike.
Thanks, Don. If you're following along in the discussion guide emailed to you previously, the blue slides will indicate which section addresses specific questions in the guide. Slide. In each of these discussions, we will pull an article from the Malaria SBC Evidence Database. This is an online searchable database of malaria SBC evidence, which includes both peer-reviewed articles and gray literature. Please take time to explore it when you have the chance. In addition to learning about Dr. Omale's research, we hope today's discussion sheds light on tips for reading and interpreting malaria SBC research for your own work. Slide. I'd like to present our author as well as two of his co-authors. Our presenter today is Dr. Ugwu Omale. Dr. Omale holds degrees in medicine, surgery, public administration, health policy, and health systems. He's a community health fellow at the West African College of Physicians. Dr. Omale is currently a senior registrar in the community medicine department of Alex Ekwueme Federal University Teaching Hospital in Ebonyi State, Nigeria. Dr. Okeke is a senior registrar in the community medicine department of Alex Ekwueme Federal University Teaching Hospital. She holds degrees in medicine, surgery, public health, and health policy and health systems. And Dr. Ugwu Omale is a lecturer at Alex Ekwueme Federal University and a consultant community medicine physician in Alex Ekwueme Federal University. She holds degrees in medicine, surgery, and public health. Welcome, Dr. Omale, Dr. Okeke, and Dr. Omale. A recurring theme in this evidence discussion series is a focus on interventions designed to influence multiple audiences and structures within the social ecological model. When we say that the social ecological model influences our work, we are acknowledging that influencing individual, social, and structural levels must be addressed to achieve positive behaviors and health outcomes. We've populated this slide with a few examples of factors at the individual, interpersonal, community, and societal levels that the study will discuss today, from standard training in the use of malaria rapid diagnostic tests, or MRDTs, to social groups, to service provider training on interpersonal communication, and even SMS reminders. The study's intended audiences interact at multiple levels on our model. I will now pass the floor to our presenter for today, Dr. Omale, who will take us through his research. Thanks again for joining us today, Dr. Omale.
So the following background informed our decision to embark on the research. As I mentioned earlier, the change in trends in malaria epidemiology over the past decade, including the reduction in the incidence of malaria in high-burden countries, malaria parasite resistance to ACTs has been emerging as reported from the Greater Mekong area, and the availability of malaria rapid diagnostic tests has made diagnostic testing more accessible, and universal diagnostic testing has become more feasible. Based on those dynamics, the WHO in 2010 and subsequently the Nigerian National Guidelines for Diagnosis and Treatment of Malaria recommended that all patients suspected of having malaria should receive a diagnostic testing before treatment. So it's worth noting that the use of malaria rapid diagnostic test, MRDT, is a key strategy for achieving this recommendation. Slide, please. So the Nigerian government, with the support of our partners, has made MRDT more available, especially at the public health facilities. However, diagnostic testing for malaria has been very low in Nigeria and Ebonyi State, where the research was done. And these are settings where the majority of febrile patients seek care from patent medicine vendors who are often responsible for over the diagnosis of malaria and over treatment with ACTs. So the practice of presumptive diagnosis and over-treatment among many health workers in Nigeria, both public and private health sector, has heightened the risk of selection pressure on malaria parasites and eventual risk of drug resistance. Slide, please. So with the documented evidence of the changing trends of malaria as mentioned earlier, and then with the heightened risk of drug resistance associated with overdiagnosis of malaria, we set out to do the research and the main goal of the research was to evaluate methods to increase demand, defenders use or request or both for MRDTs. And the primary outcome of interest was the proportion of eligible of children younger than 5 years with fever or malaria-like illness in the previous 2 weeks who received an MRDT. Eligible children were those with reported case of fever or malaria-like illness in the 2 weeks preceding the survey. So the proportion of among those children, the proportion of them that received an MRDT was the primary outcome, while the co-primary outcome was same outcome but among older children and then adults, excluding pregnant women. Secondary outcomes of interest included among those eligible children who received an MRDT, the proportion of those whose caregiver sought care with the proportion of those whose caregiver requested for the MRDT before it was done, and the proportion of those children whose caregiver also sought care with the public provider, and the proportion of the respondent female heads of households who had good knowledge and opinion about malaria and malaria diagnosis. Slide. Now, if you are following us with the discussion guide, in this section, we'll be talking about the methods. How did we carry out the study? We'll be talking about the study design, the intervention, and data collection and analysis. Slide. The study design. The study was a pragmatic 3-arm parallel open label stratified cluster randomized control trial. What does this mean? It was a pragmatic study, meaning it was carried out in real life situation as against a control study in a laboratory with strict control over the prevailing environment. But this was done in real life situation, as we'll learn better later. It was a 3-arm study. We had a control group and 2 intervention groups that were parallel, they were independent of each other. Once assigned into a group, the participants remained in that group to the end of the study. There was no crossover. And it was open label because there was no masking. And the study was stratified by the 3 senatorial zones of the state. And it was a cluster randomized control trial. We randomized a participant in clusters, which were villages or settlements. And control trial means there was a control group. Slide. The study was done in Ebonyi State, which is located in the southeastern part of Nigeria. The state is divided into 3 senatorial zones: Ebonyi North, Ebonyi Central, and Ebonyi South. Slide. Slide, please. The trial profile. We assessed clusters for eligibility. About 91 clusters were assessed and 34 clusters met the eligibility criteria. We then used a stratified multi-stage sampling, during which 18 clusters were randomly selected to participate in the study. And out of the 18, and then the 18 selected clusters were randomly assigned to 3 study groups. 6 were assigned to the control clusters, 6 to the social group clusters, and then 6 to the social group plus provider clusters. Within each arm, for example, like in the control arm, the randomization was restricted in a manner that 2 clusters fell into the Ebonyi North, 2 fell into Ebonyi Central geopolitical zone, and then 2 others fell into Ebonyi South. The purposive sampling were used to select about 4 social groups per cluster, giving rise to about 24 social groups in each of the arms. And 7 providers were also selected per cluster purposively, giving rise to 42 providers per arm. Slide, please. This was the study timeline. At implementation, we did a baseline survey, household survey, and a provider survey. After which we did intervention between November and January 2019. The intervention included a social group intervention, where there was monthly meeting with a discussion meeting with social groups, and weekly SMS reminders were sent. And the second intervention was this social group intervention, in addition with a 1-day training workshop for healthcare providers on MRDT and health communication skills. And the provider received twice weekly SMS reminders. After the intervention, by the end of January, we waited for 3 months post-intervention period. After which we did a endline survey, household questionnaire survey, and the provider survey to assess the impact of the intervention. And the analysis was done using cluster level method that was recommended by Hayes and Moulton. Slide, please. Randomization and blinding. An independent statistician using a coded list of clusters use a stratified randomization technique to assign 18 clusters into the 3 study arms. The investigators and the participants could not be blinded to the study assignment because of the nature of the intervention. Slide. The intervention, we compared 3 approaches. Control was standard practice, which involved the provision of MRDT services by public and private providers who had been earlier trained on how to conduct MRDT. So we did not intervene in the control clusters. While in the social group arm, we did a social group intervention, which involved the sensitization and education of social groups about MRDT. And then in the 3rd arm, the social group / provider intervention, we also did the social group intervention. And then in addition, we train public and private providers in health communication about MRDT. Slide. Slide. This is the summary of the trial logic model. This is a depiction of our hypothesis regarding the effect of the intervention on the outcome. So as you can see, we have the control arm, the social group arm, and the social group provider arm. And we hypothesize that the control arm will not have any effect on the community members' awareness and knowledge and preferences, and the providers' knowledge, preferences, and practice of health communication, and on the demand for MRDT. And we hypothesize that the social group intervention would have some improvement, will lead to some improvement in community members' awareness and preferences for providers offering MRDT services, and improvement in community members' knowledge of malaria diagnosis and preference for MRDT. And we expected that that will lead to a moderate increase in the demand for MRDT compared to usual practice. We hypothesize that the social group provider intervention will lead to a higher effect as compared to the social group intervention alone. And we hypothesize that it will lead to much improvement in community members' awareness and preferences for providers offering MRDT, and in their knowledge of malaria diagnosis and preferences for MRDT. Also, that the social group provider intervention will lead to some improvement in providers' knowledge of malaria diagnosis and preferences for use of MRDT for diagnosis, and to the providers' practice, some improvement in providers' client communication about MRDT. And we expected that that will lead to a large increase in the demand for MRDT compared to usual practice. Slide. Now, if you are following us with a discussion guide, we'll be talking about the results of the intervention of the study. We'll be talking about the impact the intervention had on the behavioral outcomes. Slide. This depiction is showing the result for the entire participants, both the children and the adults at baseline. The participants, the proportion that received an MRDT among both the children and the adults joined together was about 38% in the control group, about 35% in the social arm, and about 34% in the social group plus provider arm at baseline. Slide. At the end of the study, we did a post-intervention survey. The control estimate was virtually the same, while the estimate in the social group arm increased to about 63%. And that's in the social group plus provider arm increased to about 64%. Slide. Now, this is showing the effect of the intervention on our secondary outcomes of interest. At baseline, the proportion of the children younger than 5 years whose caregivers sought care with a public provider was about 38% in the control arm, 37% in the social group arm, and 45.6% in the social group provider arm. Slide. At end line, after the intervention, the proportion of the children whose caregivers sought care with a public provider decreased by 4.5% in the control arm, while in the social group arm, it increased by about 18.1%, and in the social group plus provider arm, it increased by about 14%. Slide. The proportion of the children younger than 5 years who received an MRDT, whose caregivers requested for that MRDT at baseline was about 26% in the control arm. It was about 8.4% in the social group arm and just about 6.2% in the social group plus provider arm. Slide. After intervention, during the endline survey, the proportion of those children whose caregivers requested for an MRDT decreased in the control arm by about 4.5%, while in the social group arm, it increased by about 36%. And in the social group plus provider arm, it increased by about 30%. Slide. Our main outcome, the primary outcome, which is the children under 5 years who received an MRDT at baseline. The proportion was about 42% in the control arm, about 37% in the social group arm, and about 40% in the social group plus provider arm. Slide. Following the intervention, the proportion of the children who received an MRDT decreased by 1.3% in the control arm, as against the social group arm, where the outcome actually increased by about 29.8%, and in the social group plus provider arm, where it increased by 31.4%. Slide. Our co-primary outcome was the MRDT use among children older than 5 years and adults, excluding pregnant women. This group of participants, the proportion of them that received MRDT at baseline is about 35% in the control group, 34% in the social arm group, and 30% is in the social plus provider group. Slide. At end line, following intervention, this outcome decreased by 1% in the control group, and it increased by 26% in the social arm group, and increased by about 29.5% in the social plus provider group. Slide. Now, what are the key results, the key findings of this research? One, both the social group intervention, that is the sensitization and the education of social groups, and the social group plus provider intervention, that is the addition of the provider training to the social group intervention, both were more effective in increasing demand than the standard practice, which was a control. However, the social group plus provider intervention was not more effective compared to the social group intervention alone. Slide. So from the foregoing, we understand the provider intervention component not to be effective in increasing demand. And the social group intervention, as depicted in our trial logic model, the social group intervention increased the knowledge and perception and the preferences for MRDT among the community members, which led to significant improvement in the use or request for MRDTs. Slide. Now, all these results that we've presented, what are the programmatic implications? We'll talk about, in this section, we'll talk about the strength, weakness, validity, and the methodological challenges. So what does all those results mean? How are they useful to us? What does the result indicate? Slide. In terms of the generalizability of the research findings, similar results have been reported by other studies in Nigeria and in Cameroon and in Tanzania and in Eastern Myanmar. In all of those studies, an additional training of a provider in social and behavioral change intervention was not effective in increasing MRDT use compared to basic training. And also the effectiveness of the demand side SBC intervention in our study is also supported by other community mobilization interventions. For example, a systematic review showed strong evidence that demand generation interventions involving community mobilization has been associated with increased use of ANC's antenatal care services. Slide. Now, these are the strengths of our study. We had a control group, we had two intervention groups. This provides the evidence that the observed improvement in behavior change was actually due to the intervention and not due to chance or other confounding factors. And the cluster randomization also limited bias that might be due to confounding factors, and also prevented contamination. The fact that the clusters were randomized as against individual randomization. So this helped in preventing contamination or spillover of intervention among individuals within a particular cluster. And the use of pre-post data collection method also provide evidence that the observed effect was more likely due to the intervention than to chance. For example, a phenomenon called regression to the mean, because in the analysis, we controlled for the baseline values to make sure that the baseline values were not predictors of the end result of the behavior change. Slide. Backward, please. Now, another strength of our study was that it was pragmatic in nature. The social group intervention was delivered to existing social groups in their communities, in their usual meeting time, in their venue. And this approach of sensitizing social groups can also be, because this approach leverage on already existing social structure. So it can be leveraged upon by a malaria control program who already have contact with those social structures. So the intervention can be implemented within the malaria control programs. And more so that this study was supported by the Ebonyi State Malaria Elimination Program. So this means subsequent adoption and policy implementation is likely to be more feasible. Slide. There was the main limitation of the study was that the assessment of outcome relied on self-reported behavior regarding past event, because the respondents responded to the questionnaires about healthcare seeking and use of MRDT when they had fever within the past 2 weeks. So the estimate will be subject to recall bias and incomplete memory of event. However, restricting the time period to 2 weeks, within which some event would have occurred within the past few days, because the 2 weeks include the previous day to the previous 14 days. So those events that occur within the past few days will be likely to be more memorable. And also that the primary outcome involved the respondent remembering whether a needle stick was used to collect blood from the finger or heel for testing. So that would be a very memorable event. Slide. Another limitation was that contrary to some other design practices, the clusters were randomized into the groups before baseline assessment was done. So we could not control for the baseline values during the randomization. However, we control for the baseline values during the analysis, in the adjusted analysis. Slide. Now, so what lessons have we learned after embarking on this research and assessing the outcomes, the results? We understood the provider training intervention not to be effective in increasing the demand for MRDT. And two factors stood out as we observed during the study. In the setting in Ebonyi State and in Nigeria generally, the clinic setting was not, or the drugstore setting was not too conducive for effective communication between the providers and the clients. Because as we observe, even during the mystery client assessment and during the support visit, many patients were in a hurry. They were just interested in receiving treatment, and many of them did not consent to the health communication. And also, providers also complained that during busy hours, they were not able to engage with individual patients about malaria RDT. And there's a prevailing social norm among health workers in the study setting, where the workers often focus on diagnosing the disease and instituting treatment without going further to assess clients' other background situation like socioeconomic situation and other life stressors that might be implicated in the health outcome. So even while some improvements were noted during the support visit and during the evaluation, there were some improvements in the health communication skills of the providers, but probably the effect was too modest to have any effect on the study outcome. Slide. Now, the main implication of our main finding is that now our study was the first demand-side interventional study to assess the effect of social group SBC on demand among community members. So these findings indicate that SBC intervention can actually increase the use or request for MRDT among community members in Ebonyi State and in Nigeria. And the findings also indicate that to achieve the recommended universal parasitological testing for patients suspected of having malaria, that the global efforts should focus not only on the provision of MRDT kits and basic training, but in addition to that, there should be more focused on demand creation, which may seem to be a necessary factor as observed in our study. Slide. Okay, thank you very much for your audience. I'll hand over to Mike.
Thank you so much, Dr. Omale, for this excellent presentation and for sharing your research with us. An excellent presentation with remarkable results. Now we will open the floor for discussion. Please type your comments and questions into the chat box if you have not yet done so. And we're going to begin with those questions that have already been asked. So maybe to start with, we had a question from Jude who says, this is a very good, robust design, clearly addressing the research question. I wish there was an additional arm looking at only supply side. So studying only practitioner SBC compared to the control group. Thanks again for the study. So maybe we'll pass this to Dr. Omale. When you were designing the study, was this something that you considered? Was there a constraint to doing this?
Thank you, Mike. During at the conception and the design stage, we thought of that, but we were constrained because there was no external funding for this research. So we are of the opinion that adding a fourth arm, basically will make it a 2x2 factorial design. And that will significantly increase the sample size, number of clusters, and the associated logistics that will come during the implementation. So we decided to go with the 3-arm parallel design. I hope this reason is maybe makes sense to our audience, but it was a very major reason why we did not want to add the 4th arm. Because we are set out we don't want a situation where maybe more clusters due to the factorial design, and then we will not be able to implement the research as planned. So basically, for us to be able to implement the research as planned and as budgeted for, we choose to go with the 3-arm design for logistic reasons.
Thank you so much. We have another question here from Boletito saying, can we have examples of the social groups and how often was the contact during that period? And if I can just build onto that question, in recent years, we've seen an increasing focus on the exploration of the social element of social and behavior change interventions. Working with social groups, it was an important part of this research, which I'm sure is why Boletito is asking for a little bit more detail about the work with them. Can you tell us a little bit more about the 3 social group discussions that were facilitated in each participating group? For example, what kinds of groups were these? Were there, maybe give us examples of some meeting places? And how did you and your team convince them to participate with you?
Okay, thank you, Mike. Thank you, Belatito, for the question. The social groups we used, we have different characteristics. Mainly, in the study setting, we have these groups called meetings. The general name is meetings. They are basically, it could be tribal, it could be neighborhood association, tribal association, or kingship association. Basically involves women, we call them women meetings. We also call them August meetings. We have such meeting among the men too. Among youth, we have youth meeting, youth forum. We have elders fora, that is within in a village. There are elders meeting by the elderly and the senior members of the community. And then those groups, they are also young ladies group. There are farmers group. There are even religious groups like Christian Mothers Association, for those that are familiar with like the Catholic Church. There is such association, Christian Mothers Association, Christian Fathers Association. So the groups there are different categories and different characteristics of these social groups. And basically during the recruitment, when we're doing community entry to assess eligibility among the clusters and to give informed consent, we gave informed consent to the leaders of the social groups. After getting consent from the cluster authority, from the cluster heads, and identifying the recognized social groups, those social groups that are legitimate within the clusters, we then enlisted all the social groups in the clusters, and then met with the leaders of those social groups. In some places, even other members of the groups were there, where we gave them informed consent about what we set out to do in the research and the role that they might be playing, and that it was voluntary, and we explained the benefits and the possible risk, which in our opinion, there was no possible risk. We explained to them and sought their consent to participate. And then the leaders of the social group now, after engaging with the members, the other members, for those that we met only the leaders, after engaging the members and then came back with the consent, and they actually signed the consent form. And then for those that the members were even around when we met the leaders, they had to go back and deliberate on their possible role in the study, and then came back to give us consent. We actually explained the research problem to them, the issue of overdiagnosis and overtreatment, and the likelihood of resistance. And we gave typical scenario of what happened to chloroquine, because here everybody knows chloroquine. And we're giving instance that if there's resistance to this ACT, which many of them are familiar with, issues with the situation may come when your child is febrile, maybe you suspect malaria, you rush your child to the health center, and maybe they give the main drug, which is ACT, and then it's not working. And they will paint that scenario. And then if that happens, it will be very catastrophic for us before any attempt or before any success in developing a new drug. So we painted that scenario to make them understand the problem the research was set out to address. So we got their consent. And we're happy that throughout the study, there was no attrition among the social group members. And then based on arrangement with them, most of the group discussion was in their venue of regular, where they usually have their regular meeting. Most of the discussion were there, but for some, depending on the clusters, for some, because some have meetings once a month, some once in 2 weeks, some once a month. So in the operational plan, those that their meeting will fall outside our schedule. So we had to have an organized venue and time with them. But those were few among all the social groups. Most of the social groups, the discussion held took place in their regular venue for the meeting and at their regular time. But all we had to do was to visit them earlier than the takeoff time of their meeting. So we wouldn't want to disrupt the normal meeting proceedings much. So that was I don't know whether I'm able to address the question.
Thank you so much, Dr. Omale. I see that Dr. Okeke has provided an answer in further detail in the chat. And I also see Dr. Madubweze has her hand raised. Dr. Madubweze, do you want to respond as well? I've unmuted you.
Yes, thank you very much. Thank you, everybody. I just wanted to buttress the fact that it was mostly a monthly meeting, because these groups have their meetings every month. So we try to leverage on that fact. So we had these discussions with them mostly on a monthly basis within 1 to 2 hours. So I wanted to buttress that part. Thank you.
Thank you so much. So next we're going to move to a question from Angela. And she says, thank you for this excellent presentation. For the provider intervention, it looks like the focus was on how to use MRDTs and how to communicate with clients about the testing. We've heard a lot that providers do not trust RDTs. I should say that Angela's asking this question. She works and supports our Nigeria project. Did the intervention try to influence the provider's own attitudes towards RDTs?
Okay, thank you, Angela, for the question. Yes, the provider training, the one-day workshop, was structured into 2 parts. The first part was to sensitize the providers about malaria and malaria RDT. In that there may be no time to go into the detail, but the detail is in the published article. In that first part, we conscientize them regarding the research problem, the overdiagnosis, overtreatment, increased risk of drug resistance. We did that. We went through the epidemiology of malaria, the causes, the symptoms, diagnostic methods, presumptive, which is clinical, using symptoms, microscopy, and then MRDT. We talked about the challenges facing each of all those other methods and why using MRDT now is a good strategy to overcome the overdiagnosis and overtreatment and the attendant problems. And following that, we did a demonstration of testing with virtually all of them were used to know how to carry out MRDT. So we still did a demonstration with testing with MRDT, interpreting the results, and then discussing the sensitivity and specificity, that is accuracy of the MRDT test kit, and then the recommendation of the universal testing by the WHO and our national guideline, and then on the benefit of adhering to negative test results. So that first part was structured to sensitize even the health workers themselves, because we are aware that many health workers, including the highly professional health workers, many of them have this doubt about MRDT, about the accuracy of MRDT, contrary to evidence, because evidence has been documented that even this MRDT is comparable to field microscopy. Even some studies have even stated that it is comparable to expert microscopy. Those they are in the literature. So the first part of the training was to sensitize the health workers. What we did with the social group during the social group intervention was replicated somewhat during the first part of the training. And then the second part of the training focused on improving the health communication skills of the providers, where we did some background about the health communication component and processes with emphasis on two-way communication, to have an effective communication. Two-way communication, types of communication, where the verbal, non-verbal, written, we went, and then we did a practical simulation of how to communicate with clients. They were first allowed to maybe jot down the approach they will use in communicating with the simulated patients and clients. Some of them were simulated as patients, some others as providers. And then they did that. They were asked to, the other audience were asked to jot down weaknesses and strengths of the communication skill. So when they did that, those things, those weaknesses and strengths were discussed. And then we introduced them to our own designed health communication guide of how to communicate with their patient, even in the clinic scenario, even in the drug shop scenario where there may be no time. We guided them, we give them the communication guide, and then we discuss it with them. We show the example, like a simulated client, we give the facilitators communicated with the client using the health communication guide. And then subsequently, we give the health communication guide to volunteers at the workshop to try and replicate what we just showed. And then they did that, and then we pointed out weakness and strengths, and we discussed it. So the training workshop captured the concern expressed in the question. And then they were encouraged to put, they went with the communication guide that we used for the training. They went with it. Each and every one of the providers went with it. We encouraged them to use it daily during their practice. And then during the support visit too, we discussed the challenges they encounter. That was when we learned about all those patients and clients that were mostly, many of them were in a hurry and were not consenting to the communication. However, many others too gave their consent to the communication, and we guided them we guided the providers on how to overcome challenges during the support visit. So the summary is that the training with the support visit and even the SMS text was designed to sensitize them to change their attitude and their opinion and their perception about MRDT, and also to improve their communication skills so that there now will be what do as we are sensitizing the social groups in the communities, then now the providers now will be sensitizing their patient and their client. That was the concept. So I hope the question is duly addressed.
Thank you so much. I think we have time for just one more question before we wrap up. And before we pose this last question, just want to remind everyone, we have a couple of slides left after this discussion, and to remember, please don't sign off until you've answered a very brief survey before the end of our discussion. Our last question comes from Saad. He says, thank you so much for a great presentation. I'm wondering if you considered looking at proportional change between baseline and end line, as opposed to absolute differences. He's noting that this might make differences even clearer. Were you able to, is that something that you thought about analyzing?
Thank you. I didn't get the name. Thank you for the question. Please, can you throw more light on what you mean by the proportional change? It may be different from the way I understand it. Mike?
I'm gonna throw this back to Saad. Saad, we can unmute you if you'd like to clarify, or you can add more into the chat.
Yeah, sure. Can you hear me?
Yeah.
Yeah, it was a basic, simple question. Like for example, if the baseline was 50% and it increased up to 75%, if you're comparing, absolute differences, you'd say that that's an increase in 25%. But you can also say that that's a 50% increase compared to the baseline. So that's what I was referring to. Like just if you're looking at proportional change, it will sort of, I feel it may make like the different sort of arms of the study more comparable, or the changes more comparable, if that makes sense.
Sure thing.
Okay, thank you. Is this Assad? Okay, if I understand you properly, if, for example, in the social group arm, and the baseline was, we are really around 30-something% in the among those that received the proportion that received the MRDT, and then at end line it was like 60-something%. So the absolute change is 30-something%, which is what we did. But the proportionate change you are referring to would be like, is it like 100% change? Is that what you mean?
Yes.
Okay. Yeah, I think the conclusion, either approach will give rise to the same conclusion, we believe. Whether you do a proportionate change or absolute change, we believe it will lead to the same conclusion. But for descriptive purposes, where some may prefer that, okay, you describe the result in terms of proportionate change, but we choose to use absolute change because in the, whether the change, whether the intervention is significant or not, is immaterial, whether we use proportionate change or absolute change. I don't know whether you're satisfied with the answer.
I do think that we have to wrap up just to respect everyone's time. So okay. Before we wrap up, I want to thank you again for taking your time and for presenting this excellent research. It is not every day that social and behavior change is featured in the Lancet. This is just a fantastic study. Just to let everybody know, please visit the Social and Behavior Change Impact website, the evidence database that we showed earlier. Ashley, if you can go back 2 slides. Thanks. It's a searchable database. You can choose your country. You can choose by your malaria intervention, by audience segmentation, intervention study design. Slide. The Malaria SBC evidence database also contains links to infographics. As you can see here, we have graphics that show the impact of ITN, service provider, and malaria case management SBC interventions that have been made. And there are also fact sheets that summarize the key findings. This is from over 3,600 different peer-reviewed articles, over 1,700 different gray literature reports. The fact sheets are presented in 3 malaria technical areas for NATs, case management, and service providers. And with that, we thank you all so very much for joining us today for the 6th Malaria SBC evidence discussion. Please take a moment to answer the post-webinar poll. Thanks, everyone.